Hello, everyone. Thank you for joining us for our COVID-19 Healthcare Digest. This is episode 3. Today, we're going to be discussing billing considerations with COVID-19. I'd like to thank our team members who helped put this all together, including our claims auditors, certified coders, and our clinical staff. My name is Laura Peth. I'm one of the principals of the Mazars USA Healthcare Consulting Group. Joining me today to present is one of our clinicians, Kathy Neal, a director in the Mazars USA Healthcare Consulting Group. Today we're going to cover 4 major areas. First, we'll give a brief summary of the national emergency activity that's occurred so far in relation to COVID-19. Second, we'll dive into the Section 1135 waivers. Third, we'll get into the details of coding related to COVID-19. And lastly, we're going to share some resources that really get into the details of everything we're touching on today. With that, let's go ahead and get started. Kathy, would you like to introduce yourself and start off our first section on the National Emergency Activity Summary?
Thank you, Laura. My name is Kathy Neal. I'm a doctoral prepared registered nurse in the state of California, and I'll be going over the next couple of topics with you. So it's been estimated that roughly 50 million insured Americans will eventually get the new coronavirus, which, depending on the scenario regarding transmission and hospitalization rates, could result in astronomical medical costs between $30 and $90 billion in 2020. In the middle of March, Standard & Poor's, or S&P Global Analyst, calculated that a moderate outbreak of the coronavirus would be comparable to a very strong flu season and would result in medical costs of about $30 billion this year. However, as the rate of disease transmission, severity, and hospitalization rates increase, the expenditures and costs quickly escalate. If we consider 4 million people in the United States might have a hospitalization related to this virus, the cost could escalate to more than $90 billion in 2020. To ensure the U.S. healthcare system remains viable, we see the early and accurate provider reimbursement for the diagnosis and treatment of COVID-19 as essential to business continuity in the United States. So let us briefly take a look at the events that brought us to this point. Coronavirus disease 2019, or COVID-19, is a new virus that was first recognized in China in December 2019. Coronaviruses are a large family of viruses that are common in people and many different species of animals, including camels, cattle, cats, and bats. Previous coronaviruses that infected people you might recognize were MERS and SARS. Like these, COVID-19 is thought to have originated in a single animal reservoir, most likely a bat. As a result of the increase in COVID-19 cases, the CDC activated its Emergency Operations Center on January 21st, and you may recall at that time there were some travel restrictions and precautions recommended. Due to continued person-to-person spread of COVID-19 outside of China, the World Health Organization declared a pandemic on March 11th. The Centers of Disease Control defines a pandemic as a global outbreak of disease that happens when a new virus emerges that can infect and spread between people sustainably. Because there is little to no pre-existing immunity against the new virus, it spreads worldwide. In the past, pandemics have been caused by influenza viruses. This is actually the first known coronavirus pandemic, which is why we're still learning about it. As the name implies, the novel coronavirus's clinical picture is still not fully known, but reported illnesses have ranged from mild to severe, including some illnesses resulting in death. Evidence suggests that about 16% of the COVID-19 cases will become severe, and that older people and people with chronic conditions or compromised immune systems are at the highest risk. The CDC predicted widespread transmission of COVID-19 throughout the U.S., and as of today, there are known hotspots on the east and west coasts in New York, New Jersey, Florida, the states of Washington and California, and most recently in Illinois, Michigan, and Louisiana. While aggressive efforts are being taken to reduce the transmission, we want to focus on healthcare capacity and viability and begin to address how we pay providers and suppliers for the care and supplies that are being used in record numbers. The President's declaration of the coronavirus as a national emergency on March 13th allowed CMS to waive certain stipulations in its federal payer program and open the door to state agencies to use Medicaid more freely to adapt to the pandemic. Health and Human Services ramped up its resources to drastically expand Medicare coverage for additional access by providing guidelines for the additional use and funding of telemedicine, by waiving the cost of testing and treatment of COVID-19, and by recommending hospitals begin to build capacity and resources by delaying elective surgeries. As a result of this action, 13 states applied for 1135 waivers that were quickly approved retroactive to March 1st. Florida and Washington were first, closely followed by Illinois, Mississippi, New Hampshire, New Jersey, and North Carolina. Then California, New Mexico, Louisiana, Arizona, Virginia, and Alabama followed. Additionally, the Families First Coronavirus Response Act, or FFCRA, was approved by Congress and signed by the President to increase CMS's contribution to Medicaid by 6.2% during the emergency. Because Medicaid is a shared expense between states and the federal government, this increase is intended to offset expenditures from an individual state's general fund based on the escalating medical care provided to that state's Medicaid beneficiaries. As an example, in California, the federal funding due to Medicaid expansion is 50%. With the Families First Coronavirus Response Act, the funding is temporarily increased to 56.2% across all federal Medicaid reimbursements to the state. While the dollars may seem like a windfall to the state's budget, it should be clear that any increase in funding will be significantly offset by the higher Medicaid costs due to utilization and higher enrollment due to the economy as a result of the shelter-in-place and safer-at-home strategies. In addition to increasing funding, the FFCRA also mandates all private health insurers cover the cost of COVID-19 testing without cost sharing or copays, and further prevents insurers from requiring any prior authorization for such testing. Then, on March 30th, CMS issued an unprecedented array of sweeping waivers that could be applied to all states and further increase efficiency by eliminating the need for state-specific 1135 waivers. These waivers focused on Health and Human Services priorities and addressed 4 areas: increased hospital capacity, allowing care in traditionally non-licensed spaces, rapidly expanding the healthcare workforce, putting patients over paperwork, and promoting telehealth. We'll begin to examine each of these priorities in the next section. So as we previously discussed, we're learning every day about COVID-19. After states began applying for additional 1135 waivers, CMS issued a group of blanket waivers to facilitate efficiency and reduce the burden on states applying for the individual waivers. The first priority, keeping in mind the anticipated rate of hospitalization with COVID-19, is to increase hospital capacity and create hospitals without walls. But what does that really mean? It means removing the licensing and other regulatory barriers for not only the provision of care in places that might have been previously restricted, but to allow payment for that care. CMS is waiving requirements to allow inpatient care to be delivered in ambulatory surgery centers, observation units, distinct parts of hospitals, and other excluded units such as psych units and acute rehab units when medically necessary due to the emergency. The medical records still need to reflect the level of care being provided to support billing in that excluded unit. To facilitate hospital throughput, CMS is waiving the requirement of Section 1812F of the Social Security Act for a 3-day medically necessary prior hospitalization for coverage of a skilled nursing facility stay, and in certain cases, it authorizes renewed SNF coverage for some beneficiaries who have recently exhausted their skilled 100 days without first having a new benefit period. CMS is also waiving the requirements that critical access hospitals limit the number of beds to 25 and that the length of stay be limited to 96 hours. And to support care for patients in long-term acute care hospitals by allowing the LTAC to exclude patient stays where the LTAC admits or discharges patients in order to meet the demands of the emergency from the 25-day average length of stay requirements, which allow these hospitals to be paid at the LTAC rate. To address the needs for an expanded healthcare workforce, CMS waived requirements in the following areas. It allows Medicare and Medicaid providers licensed in one state to provide and be reimbursed for services in another state to meet the needs of an emergency. An example might be call center staff or telehealth providers working remotely, or a provider who travels to an adjoining state to practice during the emergency. Further, CMS established a toll-free hotline for non-certified Part B providers and suppliers to enroll and receive temporary Medicare billing privileges. These background searches, site visits were also waived during this emergency. Revalidation and survey actions were temporarily pended, and any pending applications will be expedited. The waiver also allows all licensed providers to render services outside of their state of enrollment. States may have established their own process for notification that this is happening. We advise you to check with the licensing board in the state you will be practicing in for that process. And finally, the waiver allows advanced practice nurses, such as nurse anesthetists and nurse practitioners, to work without direct MD supervision. And hospitals may provide benefits to medical staff, such as meals, laundry, childcare, while the staff is working to care for patients and/or benefit the hospital practice. Removing or reducing administrative barriers by putting patient care over paperwork requirements is done in a number of ways under the waivers. Durable medical equipment, prosthetics, orthotics, and supplies that are lost, destroyed, irreparably damaged, or otherwise rendered unusable can be replaced without a face-to-face visit or evaluation, without a new MD order, or a new medical necessity determination. Suppliers must still include a narrative description of the claim explaining the reason why the equipment is being replaced, and are reminded to maintain documentation indicating that the DME POS was lost, destroyed, irreparably damaged, or otherwise rendered unusable or unavailable as a result of the COVID-19 emergency. There is also relief for home health agencies related to OASIS transmission timeframe. The Medicare Administrative Contractors, or MACs, can extend auto cancellation dates of request for anticipated payments during this emergency. Prior authorization requirements for fee-for-service programs and elective procedures and supplies are waived. Face-to-face assessments and annual screenings for nursing home residents has been temporarily suspended. This does not mean the screenings do not have to be done. They will have to be done eventually. Additionally, the treatment authorization request, or TAR, is still required for Medicaid services, and documentation must be included in the information field that states patient impacted by COVID-19. These TARs will be expedited and approved. Further emergency services which are not prior authorized must still be justified by medical documentation. Off-label and investigational use of medications to treat COVID-19 is allowed without prior auth. However, reimbursement requires a TAR and manual billing to prevent any unnecessary denial or payment delay. And finally, there is temporary relief to hospitals and other providers from auditing and reporting requirements. These are still required, but are delayed during the emergency. This requirement also extends to policies and procedures that may need to be written regarding new services or care provided during the emergency on a process related to COVID-19. And finally, the blanket waiver promotes the use of telehealth to expand capacity by expanding reimbursement for 85 additional services in various locations, including emergency rooms, nursing homes, home visits for home health, therapy sites such as physical therapy, occupational therapy, speech therapy, and behavioral health. Both solo visits and group visits are covered if medically necessary. Telehealth may be delivered via multiple modalities to leverage all available new technology. This would include not only phone apps that have audio and video capabilities, but also telephone, just regular telephone audio services. There are still some privacy concerns that providers need to pay attention to. You can use private or instant messaging in an email, computer, or Skype or Zoom application, but you can't use Facebook groups or TikTok. Verbal consents must still be documented. The easing of requirements means that some services do not have prior limitations that prevented reimbursement. For example, home remote monitoring of oxygen saturation levels by pulse oximetry is now allowed when only one chronic or acute condition exists. It is important to remember that services must be related to the COVID-19 emergency. Another area impacted by the easing of requirements is the direct supervision of clinical staff when providing billable services. During this emergency, the appropriately credentialed office or clinic staff can be supervised via virtual technology, allowing for reimbursement of billable services while the supervising physician may be in a different location. Telehealth can be utilized for both new and existing patients and is reimbursable at this time at the same rate as an in-person visit. So in summary, when the President declared a national emergency on March 13th, it allowed Health and Human Services to issue blanket waivers for certain Medicare and Medicaid programs to improve efficiency and remove administrative barriers. It is important to remember that these waivers were retroactive to March 1st unless noticed elsewhere, and that all waivers will end at the conclusion of this emergency. Laura, on to you.
Thank you so much, Kathy. Let's get down into the data now and talk about coding related to COVID-19. For reimbursement and research purposes, it's very important that we correctly use coding related to COVID-19. Within this section, we'll review coding in three major categories. The first will be inpatient, laboratory, and telemedicine coding, specifically related to detecting and diagnosing COVID-19. The second will be coding for COVID-19 related encounters. And lastly, we'll go over coding for potential COVID-19 related encounters. One important note, each state decides what they will cover and pay under Medicaid. For this reason, we will not be diving into specific reimbursement rates during this presentation. Rather, our emphasis here is on accurate coding so that regardless of your specific state's Medicaid rules, you will have appropriate documentation to get fully reimbursed in the future. So let's talk about coding for detecting and diagnosing COVID-19. CMS released a new healthcare common procedure coding system code for providers and laboratories to test patients for COVID-19 on February 13th. As you can see on this slide, there's one code for tests developed by the CDC and a separate code for non-CDC developed lab tests. A few limitations and considerations to keep in mind. These codes are retroactive to February 4th. There is a quantity limit to 2 tests per day per patient. And these codes do fall under the presumptive eligibility benefit. Continuing with coding for detecting and diagnosing COVID-19, let's talk about some of the codes for virtual communication. Code G2010 should be used for remote evaluation of a video, email, or images of an established patient without an associated E&M service within the last 7 days. Whereas G2012 should be used for an actual virtual check-in of that established patient, also not associated with an E&M service within the last 7 days. There are a few limitations and considerations to keep in mind. Virtual visits cannot be billed by federally qualified health centers, rural health clinics, or Indian Health Services at this time. In the state of California, the Department of Healthcare Services is seeking flexibility for Medi-Cal on those matters. Let's talk about the ICD-10. Within the ICD-10, there are a few codes that we need to keep in mind. U07.1 is for the COVID-19 virus when it is identified and confirmed by laboratory testing. U07.2 is for the COVID-19 virus when it is clinically diagnosed, based on a clinical review or epidemiological diagnosis where laboratory confirmation is inconclusive or simply not available. Both of these codes may also be used for mortality coding as cause of death. We're going to quickly go over ICD-11 codes. In the US, we're still using ICD-10, but many other countries are using ICD-11. So for our international audience, I will briefly go over these codes. RA01.0 is similar to our code on the prior slide of U07.1. This is defined as a confirmed COVID-19 diagnosis by laboratory test. RA01.1 is similar to our ICD-10 code of U07.2, and this is assigned for a clinical diagnosis, suspected or probable, of COVID-19. So moving on, now that we have our diagnoses codes for COVID-19, whether it was diagnosed through a laboratory test or a clinical review, what do we do for issues directly related to that COVID-19 diagnosis? We have sets of codes that we can use in these circumstances, but we always want to make sure when there is a valid COVID-19 diagnosis that we combine them with code B97.29, which you'll see repeated multiple times on the next few slides. In each circumstance, when we're talking about issues directly related to the COVID-19 diagnosis, we'll have a code for that issue, but you must also include B97.29. So on this slide, you can see the codes for pneumonia due to COVID-19, acute bronchitis, bronchitis not otherwise specified, and if we continue, some of the other common related issues include lower respiratory infection, acute respiratory distress syndrome, or ARDS. So for any of these conditions related to a COVID-19 diagnosis, we need to use the specific code on these slides as well as B97.29 to designate this as related to a COVID-19 diagnosis. So the last thing we want to talk about in coding is what we should be doing for patients that are presenting with COVID-like symptoms, but there is no definitive diagnosis, either by a laboratory test or a clinical diagnosis. It's still important in these cases that we use the right codes, and it's important for a couple reasons. First of all, once all of this settles down a bit, and even now, we need to be doing research. And in order to do accurate research, we need good encounter data. So let's make sure we're using our codes appropriately, even for folks who don't have a bona fide diagnosis of COVID-19 when they do come in with related symptoms. So let's walk through some of the distinction here. For a patient presenting with any sign or symptom of COVID-19, like a fever, cough, shortness of breath, but there is no definitive diagnosis because there has been no laboratory test, and from a clinical assessment, it has not been determined for sure that this person has COVID-19, go ahead and assign the appropriate code for each presenting sign and symptom. And we've listed a couple of examples here. Again, this is when you do not have a diagnosis of COVID-19. The last 2 points on this slide also are clarifying. We need to keep in mind, as Kathy mentioned earlier, that coronaviruses are a large family of viruses, many of which cause what we would consider to be the common cold. For this reason, there are already codes in ICD-10 related to a coronavirus infection unspecified, and that code is B34.2. B34.2 should not be used for anyone who has a diagnosis of COVID-19. It's not going to show up correctly in your data, you won't get reimbursed correctly, and that patient encounter data will not flow into research appropriately. So do not use B34.2 for a coronavirus infection unspecified unless it's an accurate code to use. If someone has a COVID diagnosis by lab or clinical exam, or is suspected of having COVID-19, we've already gone over those codes earlier in the presentation. B34.2 is more for a common cold. Additionally, if the provider documents a suspected, possible, or probable COVID-19 diagnosis, you don't want to assign B97.29. As we explained in prior slides, B97.29 is the code to use for a bona fide clinical or laboratory diagnosis of COVID-19. Instead, for suspected, possible, or probable cases, assign a code explaining the reason for the encounter, such as a fever, shortness of breath, cough, etc. So let's take a look at those resources. Kathy, do you want to review the resources for everyone?
Sure. On the next couple of slides, you'll find several references listed here that are related to the COVID-19 national emergency and the resulting 1135 waivers. This is a novel coronavirus, and our knowledge is changing daily about this topic. It is important to make sure that you are referring to the most current resources available when making billing and coding decisions for your organization. So there are a number here from the state regulatory, from CMS, as well as some articles from S&P and fact sheets that will help explain some of where we got the information and resources you can go to try and get the most updated information.
Thank you, Kathy. And here at Mazars USA and the Healthcare Consulting Group, we're compiling this information and presenting it in short videos that you can watch at any time in order to be a resource to the industry. If you do have any questions or we can be of any assistance, it is our goal to be as helpful as possible during this emergency. Please feel free to reach out to either Kathy or myself directly. There's also a couple links on this slide to our COVID-19 response page, which has a lot of different information, not all of which is specific to healthcare, but more operational and business facing regarding how to handle the pandemic. And additionally, we have our healthcare specific webpage listed here as well. And lastly, I know Kathy and myself and the entire healthcare consulting team, as well as Mazars USA, would like to offer our heartfelt thank you to all of the healthcare workers on the front line right now treating our patients throughout the country. Thank you so much. Have a wonderful day.